You might be the godfather of dental water lines, but to me, you're the fun uncle. It's just crazy times, period. And let me introduce you. This would be the way I'd introduce you. I talk to a lot of really smart people who are smart enough to go to OSAP. They listen to really smart lecturers. Those really smart lecturers listen to really smart lecturers. And when those people have a tough question, they ask John Molinari and Eve Cuny and all the really smart people. And when those people have a question they can't answer, they call Dr. Shannon Mills, especially when it comes to dealing with water.
Oh, come on.
You might be the godfather of dealing with water lines, but to me, you're the fun uncle. And I just love.
Thank you for not making it the funny uncle.
The funny uncle, you're both. But let's dive in and have some fun. Well, why don't we just start with the big picture, can you tell us a little bit about how the coronavirus has spread and what it means for dentistry moving into June?
Okay, well, it's a complicated question, and I'm not going to get deep into the immunology side of it, but for the virus to cause infection, it has to have a portal of entry. And the primary portal of entry is the oropharynx, the eyes, the conjunctival tissues, and the pulmonary tissues themselves. This is how the virus appears to get into the human body, and it does it by attaching ACE2 sites in the cell, which is where the spike protein hooks up. So that's how they get in, start to replicate themselves. So the virus now has to have a mechanical way. It's a mechanical thing. It's physics now, not biology, of how it gets into the lungs or tissues. And we know that, like many viruses, ranging from herpes simplex to colds to flu, one of the most common things is hand contact, hands touching contaminated surfaces, shaking hands with the person who's just picked their nose, which is a gross thing to say, but it happens. And you get the virus on your hand, your eye itches, and the next thing you know, you got a virus in your body, whether it's coronavirus or one of these others, the infection can start. You've got a viral load that's sufficient to begin the process. So that's one thing we know, is that contaminated surfaces are a problem. Now in dentistry, I'm just taking a aside real quick because I want to try to reference this back to what we've been doing. For the last several decades following the OSHA bloodborne pathogen standard, we've relied on standard precautions, but they're almost entirely based on cleaning high contact surfaces that are touched during clinical procedures, with environmental surfaces being seen as a very low risk of transmission of disease, of hepatitis B, C, and HIV. Very low likelihood that environmental surfaces that haven't been directly touched, visibly contaminated, can transmit. Different game plan. These surfaces now that you don't see the virus on. We never worried about cleaning doorknobs between patients. We never worried about a lot of things like that weren't touched as part of the treatment. Now we have to think about that. So it's different. So that's number one, contact with contaminated surfaces, live surfaces as in hands, or surfaces like, cell phones or coffee cups, or you can't see it but countertops. Got it. Okay. So that's one way. The other way it's spread is through droplets. We know this for sure. It's spread through small droplets. And there's a whole set of droplet precautions as a tiered standard above the bloodborne pathogens standard precautions that looks at keeping these droplets out of our tissues, particularly the eyes and the mouth and the nasal tissues. So we do a pretty good job with that in the dental office now. For the most part, even a standard surgical mask is capable of producing that level of safety. Now, safety eyewear, the safety eyewear we're typically used to using, and I don't have my loupes with me, I can show you, don't have adequate protection around the sides and underneath to keep droplets out of your eyes. So we didn't worry about it because the likelihood, you had to have a pretty big bolus. It was possible, but you had to have a pretty big bolus to get hepatitis B from a droplet, which you could. It's documented. It's definitely proven to happen in chimpanzees, lab animals. But we thought that protection was probably adequate, and the proof's in the pudding. We have not had a lot of transmissions of hepatitis B, HIV, or HCV, no documented HIV transmissions from patients to healthcare workers in dentistry. So we did a good job with what we did. We've got to go up the game. And unfortunately, that's going to be a challenge for us. So now we go back. The last piece of this, the next tier is the thing we call aerosol. And the way an aerosol differs from a droplet is the droplets have a sufficient mass that typically within, and this is why the 6-foot social distancing thing is in place, within 6 feet of where the aerosol is generated by sneezing, coughing, or a dental procedure, those droplets tend to drop out onto the floor, and by the way, onto surfaces. Okay, that's how we get that other thing we talked about, the contact thing. So once those things can be brought into the mouth, they're typically not inhaled into the lungs. They're typically they land on the oropharynx, the nasal passage, or the eyes, in the eyes. The third thing, the next level up, is airborne transmission or aerosol transmission. So particles smaller than 5 microns, which fall into the range of something we call respirable droplet nuclei, which is the terminology we mainly take from tuberculosis. Unlike coronavirus, to catch TB, you have to get the bacillus into the terminal alveoli of the lungs. It has to get deep into the lungs to cause disease. You don't get it from it landing on your lips or your tongue or your eyes. So you have to have that happen. The respirable droplet nuclei have to be just the right size to carry that tubercular particle into the lungs. And it's usually because the bacillus is in a droplet, and as it evaporates, it reaches the size where it can be suspended in the air, pulled into the lungs. Some of the smallest aerosols have a hard time being pulled deep into the lungs. So that's another whole issue, and I'm not going to get into all of that. I'm not an expert in that area, so I'm not going to go much further than that. But we do know this, that the aerosols, we don't know how transmissible, how much they participate in the transmission of coronavirus. Right now, it's still kind of an unknown. And I like to quote, I'm not a big fan in many ways of Don Rumsfeld, but he did say one thing during the Gulf War that caught him a lot of flack, but it's true. You know, we have different knowns. We have the known unknowns, and then we have the unknown unknown. So aerosol transmission falls into the category of a known unknown. We still don't have a clear picture. And we have, even in the CDC guidelines, conflicting statements. We have one place where it says aerosol transmission is unlikely early in the document, and further down it cautions against, it advises you to protect yourself from aerosols using N95 respirators for all aerosol generated procedures.